Alright, let's talk about ultrasound and pregnancy. Abdominal transducers produces 5 hertz, 5 megahertz, and vaginal producer is 5 to 10 megahertz. First trimester ultrasound is before 14 weeks. Embryo should be visible by transvaginal ultrasound with mean gestational sac diameter of 25 millimeter. If the embryo is 7, if the embryo is 7 millimeter, which is 6 weeks 5 days, there should be in cardiac activity. We should document fetal number and chorionicity if possible. Second trimester ultrasounds, we use bipyramidal diameter measured at the level of thalamus and cavum septi pellucidii. Head circumference is more accurate than bipyramidal diameter because the head shape is not a contributing factor. Femur length should be excluded. Femur length should exclude the distal femoral epiphyses, and the abdominal circumference should be at the level of umbilical vein, portal sinus, and the stomach. Growth scans should not be done less than 2 weeks, usually 3 to 4 weeks, due to ultrasound errors up to 20%. Ultrasound and patient safety. Ultrasound energy delivered to the fetus cannot be assumed to have no effect on the fetus, so it should be done only when indicated. So ultrasound for dating when it's less than 5 weeks. If there's a discrepancy for 5 days difference, then ultrasound, we should go by the ultrasound. If it's 9 weeks to 15 and 6, it should be 7-day difference. 16 weeks to 21 weeks, it's 10-day difference. 22 to 27 is 14-day difference. After 28 weeks, it should be 21-day difference. At less than 14 weeks, crime run length is accurate. After 14 weeks up to 22 weeks, head circumference is the single most predictable parameter of age. After 28 weeks, the best single measurement for age is femur length. Highest ultrasound indication for aneuploidy, increased NT. 1/3 of increased NT have chromosomal abnormalities, and 50% of them are trisomy 21. Aneuploidies for increased NT also involved trisomy 13 and 18, monosomy X or triploidies. 21%. So if the thickness is 3.5 to 4.4, there's a 20% there is a aneuploidy. If the thickness is 5.5 to 6.5, there's a 50% chance of aneuploidy. If it's 8.4 or above, there's a 75% chance. There's also risk for cardiac defects. Septal defect is the most common. Other anomalies are 3 times higher, such as hydrocephalus, agenesis of lung, atresia of stomach or intestine, osteodystrophy, diaphragmatic abnormalities, other genetic syndromes, Noonan's, SMA, the George management offers CVS or amnio, microarray and genome sequencing if euploidy to detect Noonan syndrome. We should get a fetal echo at 20 weeks. So that's the NT, and then other ultrasound indication of aneuploidy also is absent or hypoplastic nasal bone or cardiac defects. And then also cystic hygroma in the first trimester. It indicates Down syndrome in the second trimester. Increased risk for Turner. Trisomy 13 have microcephaly and micronathia, short overlapping digits. Trisomy 13, microophthalmia, microcephaly, cardiac defects, cleft lip and palate. Doppler ultrasound can assess fetal anemia associated with red cell alloimmunization, fetal infection, and fetal hydrops. Doppler of peak systolic velocity of MCA if that is greater than 1.5 times the medium of modem medium. What is MOM again? It's a predictor for severe anemia, but it's not as accurate after 34 weeks. Fetal weight less than 10 percentile is indication for further evaluation by MFM. 20% discordance in twin warrants a further evaluation. Serial ultrasound with serial growth with ultrasound can be done every 2 to 4 weeks. Umbilical artery assessment decreases fetal mortality in FGR. It decreases fetal death by 30%. Absent or reverse end-diastolic flow equals poor perinatal outcome. Monochorionic twins should have serial ultrasound every 2 weeks, starting 16 weeks. Every 4 weeks for di twins, not starting at 16 though. Increased congenital heart defects. Fetal echo is considered for monochorionic twins. Non-optimal dating, greater than 22 weeks without an ultrasound. Amniocentesis is not recommended as routine when considering delivery. BPP, so fetal tone, first appears at 8 weeks. Gross fetal movement appears at 9 weeks. Breathing appears at 21 weeks. Fetal reactivity starts at 26 weeks. Single deepest pocket less than 2 centimeters should be used as opposed to AFI of less than 5 for oligo. Oligo is associated with genitourinary abnormalities, PROM, uteroplacental insufficiency, post-term pregnancy. Polyhydramnios, which is defined as single deepest pocket greater than or equal to 8, or AFI greater than or equal to 24. That's pre or gestational diabetes, fetal structural or chromosomal abnormalities, fetal infection, twin transfusion, fetal anemia due to isoimmunization, or fetal maternal hemorrhage. Random notes. VSD is the most common fetal cardiac abnormality. Umbilical artery resistance decreased throughout pregnancy. Growth scan in the third trimester for patient greater than 40 years old due to risk of SGA or LGA. Due to risk of stillbirth, antenatal surveillance is warranted for 40 plus year olds. Rate start increasing at 34 weeks, and that's when it should start doing the antenatal surveillance.